We're going to continue our talk today and talk about radiography of the lungs. This is a pretty difficult topic that a lot of students and veterinarians struggle with lung patterns. Well, I'll try to break it down and make it as simple as I can. Basically, I want you to be able to recognize and describe radiographic changes in the lungs, give the different patterns, recognize alveolar, bronchial, nodular, and interstitial pulmonary patterns. Recognize lung disease patterns, distribution and location, and list differentials for the lung changes based on the location and distribution, and then be able to recognize these specific processes that happen in the lungs. We've done this a little bit in going through thoracic radiographs by breaking it into compartments, extrathoracic, pleural space, pulmonary parenchyma. We've talked about the mediastinum somewhat. We haven't talked about the heart, but when you go through each of these, you can ask yourself some questions. And so one of the things we do in the lung is basically, is the lung normal or abnormal? If it's abnormal, is it increased or decreased in opacity? You need to recognize the anatomic location or the distribution, and then the pulmonary pattern. And then putting those together will help create your differential list. Remember, when you evaluate pulmonary structures or the lungs, that the lungs kind of should go all the way out to the chest wall and to the diaphragm and down to the sternum. And so we should see small pulmonary vessels overlying the heart and going out to the peripheral margins of the lungs. The lungs are predominantly air-filled, and we'll see these vascular markings. There's fairly distinct demarcation because they're surrounded by air. So make sure you search the entire thorax and all parts of the lungs. Anywhere you can see pulmonary vessels, there can be a lesion in the lungs. Students and veterinarians and people in general often fail to evaluate the part of the lung that summates with the heart and the liver on the lateral views, so make sure that you're looking at that. So make sure you're looking over the heart, see how well you can see these vessels coming in, bifurcating and branching. You can see pulmonary vessels going all the way to the peripheral margin of the lung, and then you can see these vessels overlying the liver. So remember, when you evaluate the thorax, to look at that entirety of the lung. When there are changes, we're going to try to describe those changes as to diffuse, focal, central, peripheral, lobar, or multifocal. We'll describe the pattern and then look at the mediastinum and where the mediastinum is. And then a lot of people like to look at severity or how severe the disease is, because that may gauge for future reference. Just an example of a diffuse distribution in that all of the lungs are affected. This would be a focal or lobar distribution in that only this caudal subsegment of the cranial lung lobe is affected. And then this would be a multifocal distribution where there's soft tissue opacities within the lung in various lobes or various positions. So diffuse means that all of the lung lobes are affected. So again, we have increased opacity throughout all of these lungs. It's hard to see the margins of the heart. It's hard to see the margins of the diaphragm. There's vessels in this part of the lung, but they're very difficult to see. On this side, we have this soft tissue or fluid opacity within the lung. Multifocal just means that it involves multiple focal regions throughout the lung. Sometimes it can be patchy, and sometimes it can be very distinctly demarcated. This is multifocal soft tissue nodules, in that there are numerous soft tissue nodules multifocally throughout the lung. This would be a focal distribution where we have a solitary soft tissue structure or soft tissue opacity that's only located in this right caudal lung lobe. And it only involves this single segment, so it's a focal lobar distribution within the caudal lung lobe. Sometimes we'll have kind of a more centrally located distribution, such that the periphery of the lungs, down here cranially, ventrally, and caudally, is normal, but in this central or perihilar region, it might be increased in opacity. This is often hard to see because it summates with the heart, but notice how you see vessels, and then over here these vessels are more difficult to see. The vessels in this region are more hazy and not as clearly demarcated as the vessels at the periphery or in this portion. There's also a peripheral distribution. So this opacity within the lung is located peripherally. It goes out to the margins or the edge of the lung, but the central part of the lung is more normal. So this is a caudal peripheral distribution, and it's hiding over the diaphragm and over the diaphragm here where we can't see these vessels. But there's increased opacity within the lung. There are three classic distributions that you need to be familiar with, and we'll talk about these in detail, but there's specific diseases or processes associated with these specific locations within the lung. This cranial or ventral distribution of the lung is very common for bronchopneumonia. Right and left lateral views are going to be very beneficial when you're assessing for bronchopneumonia because you can see the right and the left lungs from each lateral versus it getting summated and atelectic when it's recumbent or in the dependent portion. Because remember, on a right lateral view, we're mostly assessing the left lung, and on a left lateral view, we're mostly assessing the right lung on these lateral projections. This increased opacity that occurs in the perihilar region, which is not present in this animal, this is normal lung, but just this region is where you're going to see heart failure or cardiogenic edema. It's the classic distribution for cardiogenic edema. And then distribution in this caudal dorsal aspect of the lung is typical for non-cardiogenic pulmonary edema. Again, this lung is normal, but if you see opacity in this region, your top differential is going to be non-cardiogenic pulmonary edema. Again, when you are assessing the thoracic structures, you need to assess the location of the mediastinum. So here's the trachea, which is part of the mediastinum or in the mediastinum. Here's the bifurcation. Notice how the trachea is displaced to the left in this animal, and there's increased soft tissue opacity in the right thorax. So this suggests that there's some space-occupying disease in the right side that is pushing the trachea to the left. On this animal, you'll notice that the mediastinum, so the heart and the trachea, are slightly displaced to the left. However, there's nothing pushing it. It's just that there's reduced volume on the left side. So these lungs are atelectic or not fully inflated, and that's why there's increased opacity in these lungs with the mediastinal shift toward the opacity. When we evaluate the lungs, it's important, or I think it's helpful for you to remember the anatomy or the histologic structures that are present within the lung. So within the lung, we have vessels. So these are our little vessels. You will have bronchi. Here's the bronchi with a bronchial wall. And then all these air-filled structures are the alveoli. And then the interstitium. And the interstitium is going to be all this connective tissue that is around the alveoli, the alveolar walls. It's in this the lymphatic walls, the periconnective tissue on the bronchial walls. So all of this tissue is the interstitium. And so if you think about it, the patterns that we see radiographically are going to be associated with what is present histopathologically. So there's going to be a vascular pattern if the vessels get big. If the bronchial wall is affected, we will have a bronchial pattern. If these air-filled alveoli are no longer air-filled, we'll have an alveolar pattern. And if it is affecting all of this interstitium or the tissue, then it's an interstitial pattern, which can be either structured or nodular or non-structured. Most patterns are often mixed, and so we'll see a little bit of both compartments or numerous compartments of the lung affected. But when you evaluate the lung, you want to try to put it into one category because that will narrow your differentials. This is just an image of the main pulmonary patterns that we're going to describe with time. And so you'll be able to recognize these. This is the alveolar pattern. This is a bronchial pattern. We have lots of thickening of the bronchial walls. There's an air bronchogram and an air bronchogram for the alveolar pattern. Interstitial pattern is just increased gray or haziness to the lungs. And then a nodular pattern where there are defined soft tissue nodules within the lungs. I'm going to use these drawings to depict a normal lung and try to illustrate abnormal lung. So in the normal lung, we have the pulmonary vessel, so we can see the artery, the bronchus, and then the vein. The bronchus is typically between the artery and the vein, and the artery is going to be cranially located, with the vein caudally located, and on a ventrodorsal view, the artery will be laterally located, with the vein medially located. So if we pretend like these are the lungs, these white linear structures are going to be the vasculature that goes and branches into the various lung lobes, and then we have air-filled structures around it, as well as the bronchus between the vessels. So illustrating the same thing, the pulmonary artery, the bronchus, and the vein with air surrounding it. So when we have changes, again, we're going to describe that location or distribution, which we've already discussed. And now let's talk about the various patterns. This is an alveolar pattern, then this is a nodular pattern. When you have changes in the lung, one of the first things that you decide is, after you decide it's normal or abnormal, is there increased opacity in the lung? If there's increased opacity in the lung, ask yourself if you see nodules or masses. And if the answer is yes, you have a nodular pattern. In the nodular pattern, differentials include neoplasia, granuloma, and occasionally abscesses or hematomas. I believe I gave you the acronym CHANG, C-H-A-N-G, in the past. And these are those same things with the exception of cyst. So hematoma, abscess, neoplasia, granuloma. However, again, neoplasia and granuloma are going to be most common. If there is not nodules, we'll ask some more questions later. Let's talk about the nodular pattern. Some people refer to this as a nodular interstitial pattern or a structured interstitial pattern. I prefer you just say there are nodules or it's a nodular pattern. So for a nodular pattern, again, you're asking yourself, do I see nodules? And if you see soft tissue nodules throughout the lung that are not associated with the vasculature or the ribs or other structures, then this is a nodular pattern. This is just illustrating some of those nodules. There's more that are not outlined. So this would be a nodular pattern. Here's another illustration with soft tissue nodules multifocally throughout the lung. We can see pulmonary vessels coming and branching to the lung periphery. Some of these nodules, like this nodule, is in the plane of this vessel, but it's bigger than the vessel. So again, if we have various soft tissue nodules within the pulmonary parenchyma, we're going to call this a nodular pulmonary pattern. Sometimes these nodules are severe and diffuse, and they may be very small, but if you look at this closely, there's multiple tiny soft tissue nodules that are just coalescing all throughout. So this is just a summation of lots and lots of nodules throughout the lung. More illustration of some severe nodular pattern where you see this overall increased opacity throughout the lungs. But if you look close at this, it tends to be a bunch of little soft tissue nodules. And so this is just an illustration of a severe nodular pattern. This guy has a metallic ballistic in the cranial abdomen from where he was shot in the past. Some nodules are small and can be hidden and summating underneath additional structures. So here's the aorta. These are ribs. but there's an extra soft tissue nodule over here. So just remember to look at all parts of the lungs for that. These little nodules are smaller, but notice how there are vessels that can be traced past them. So these are end-on pulmonary vessels. And so make sure that you're not looking at an end-on vessel when you call pulmonary nodules. So check and see if there are vessels that are adjacent to it that are very similar in size. Versus this guy is much smaller, or much larger, than the pulmonary vasculature around it. Differentials for nodules, again, are neoplasia and granulomas. Granulomas are typically fungal, but can be inflammatory or bacterial. And then we have primary metastatic neoplasia. Occasionally, we'll have abscesses and hematomas. We just looked at what end-on vessels look like as a differential for a soft tissue nodule. Some other things that we want to look at are osteomas, which is this mineralized opacity. So if it's a mineral and it's a small nodule, it is an osteoma or osseous metaplasia, which tends to be a benign process. This is the map of the United States and where the fungi occur in the United States, but I would encourage you to be familiar with the different types of fungus that may be endemic to your area, because that will contribute to that nodular pattern. Let's talk a little bit more about other nodules or other things that cause the appearance of nodules. End-on vessels, the mineralized nodules that we just talked about, which are typical benign osseous metaplasia or osteomas. And then sometimes you can have things on the chest wall or cutaneous tissues that makes it look like it's in the lung. This is just an example of an end-on vessel. Here's a soft tissue nodular focus, but if you trace it, there's a vessel that's coming right to it. It's the same size. Same thing here. Here's a vessel, and this is smaller than that vessel. It's branching off and coming directly at us. So all of those are examples of just end-on vessels. These nodular foci throughout the lungs are all mineral opaque. And so these mineral opaque structures are osseous metaplasia. They're only 1 to 2 millimeters, and they're really opaque, so they're easy to see. They're more mineral, they're bone opacity versus soft tissue opacity. These are benign. They're very common in older dogs, geriatric dogs, and they are not clinically significant. You have to be able to differentiate a nodular pattern from these structures, and if you look at this animal, it looks like it has nodules in the lungs. However, when we start looking at these, it actually seems to be contiguous with structures around it. So this is a tubular structure. So these are actually examples of end-on severely enlarged pulmonary arteries. This is very common with heartworm disease, and you can also see it with pulmonary hypertension. Sometimes we'll have nodular structures that we see on one projection, but we don't notice on the other projection. But if you notice, this guy has mammary tissue in this region. And so make sure what you're looking at is actually in the lung versus on the skin. And in this case, this is just normal mammary tissue that we're looking at. If you're ever not sure, when you see a nodule, whether it is a cutaneous lesion or not, you can place a radio-opaque marker like barium or tape a BB to whatever skin nodules you feel, and retake the radiograph and see whether you're looking at the same thing or something that's different. And then occasionally we'll have ribs that may look like nodules. So if I look at this radiograph, I see kind of this region of increased opacity here and here that looks nodular, but if I follow it, it is just connected to the rib, and this is the costochondral junction where it's just a little flaring and a little prominent in this animal. So those are normal structures that can be incorrectly interpreted as pulmonary nodules when they're outside of the structures or the lung. So we went through our algorithm when we noticed that there were nodules. We gave our differentials. So what do we do if there are not nodules? Then we're going to have to look further for what pattern in the distribution to narrow our differentials down. So the next question you can ask yourself is, can I see vessels? And if the answer is no, then you have an alveolar pattern. So let's look at an alveolar pattern. If I look cranially in this lung, I can see a pulmonary vessel, so this is going to be the artery. And then here's the vein coming down and branching and bifurcating. So if I look up here, I see lung with little white linear soft tissue structures which represent the vessels. If I look over this portion of the thorax, however, I see increased soft tissue opacity. I no longer see any vessels, and all I see is the airway coming and bifurcating. And so this is an air bronchogram or an alveolar pattern. So when we see fluid or soft tissue opacity and only see the airways and no longer see the vessels, it would be an alveolar pattern. Here's a graphic depiction of the normal lung, and then the abnormal lung. Notice that we no longer see those vessels because the lung has soft tissue or fluid opacity in it. So cranially, we have normal lung. Here's the artery, here's the bronchus, here's the vein, and notice how you can see these vessels come and bifurcate. But if you look over the heart here, you see the opposite. So we see the black airway coming and branching, but I just see soft tissue or fluid outside of it. And so I can no longer see those vessels. This is an air bronchogram or an alveolar pulmonary pattern. Air bronchograms are seen when gas remains in the bronchus within a region of lung in an alveolar pattern. So it looks like a black tree branching on a white background. So that's kind of the complete opposite of the normal lung. And this alveolar pattern is the hallmark, air bronchogram is the hallmark of an alveolar pattern. So we no longer see those vessels and such because there's fluid in all of these alveoli, and it border effaces with the vasculature, and so you may only see little bits of air in the airway on that radiograph. So here's the air bronchogram illustrated graphically for you. So there's air still coming and branching. We no longer see the vessels. We have that airway coming and branching. So fluid is the same opacity as blood, and so we can no longer see those vessels. You'll also notice that we no longer see the demarcation with the heart or the liver because of the border effacement of the soft tissue or fluid opacity. So radiographically, with an alveolar pattern, you'll have those branching trees or air bronchograms, the inability to see the pulmonary vessels. You'll have border effacement or silhouette sign with soft tissue structures like the vessels, the liver, the heart. You may see a lobar sign, which is a border between the alveolar lung lobe and the adjacent air-filled lung lobes. Here's that alveolar pattern. Again, it looks like that branching tree with a white background. So normal lung versus this middle lung lobe has an alveolar pattern. This animal has an endotracheal tube, and then there's an alveolar pattern kind of in the ventral aspect of all the lung lobes. So I see the airway branching, do not see any vessels. I see the airway branching, I don't see any vessels, and there's uniform soft tissue or fluid opacity. And the same thing here, and there's only a little bit of more normal lung at this caudal dorsal periphery. This is another alveolar pattern, but it has a different distribution. So this distribution is in that caudal dorsal lung, which, as we learned, was associated most commonly with non-cardiogenic pulmonary edema. We can see some airways, and then there's just uniform soft tissue opacity around it. It border effaces with the diaphragm. We have a hint of a couple of vessels because remember that we're looking at, kind of 3 dimensions in 2, so you may see a little bit of the other lung lobe coming through. Here's that air bronchogram with border effacement with the heart and the diaphragm or liver, so we no longer see those liver margins. So this just really shows you the normal lung versus the abnormal lung. You can see vessels here. We can't see vessels with that alveolar pattern. This is to illustrate the usefulness of the multiple lateral views. We have a ventrodorsal view. We have increased opacity in this right cranial lung lobe. The left lung looks pretty good. The caudal lung, there's some mild increased opacity. I have a pretty distinct demarcation right here. This is that lobar sign where there's soft tissue or fluid within this lobe, but it's up against normal lobe. If I look at this right lateral view, I can still see pulmonary vessels. They're kind of indistinct, but I still see little faint branches overlying the heart. Versus when I do the left lateral view, so remember, the left lateral view, we're going to be better at assessing this right lung. You can note that you can easily see these air bronchograms. So I see the airway coming down and bifurcating with nothing but fluid outside of it, and the airway bifurcating with fluid. And then there's a lobar sign. So there's this sharp demarcation between this alveolar pattern and then the normal air-filled lung. Alveolar patterns do not have to have air bronchograms. So if that bronchus is completely filled with fluid or cells or becomes completely collapsed, then the air part disappears and all we will see is soft tissue or fluid opacity. I've mentioned the lobar sign a couple of times, and it's a sharp delineation at the margin of the alveolar pattern where the alveolar pattern ends and the normal or more normal lung begins. It's useful to draw your attention to the alveolar pattern, and it indicates that the process is focal or that it's not diffuse where all lung lobes are affected. So here's the graphic illustration of that lobar sign. So this is our alveolar pattern where the soft tissue fluid opacity up against the normal lung. So here is the lobar sign where there's air-filled cranial subsegment of this left cranial lung lobe, and then an alveolar pattern in the caudal subsegment. We can see a little bit of an airway, but we don't have a really good air bronchogram. However, we have a really nice lobar sign. Another illustration, this one happens to be in the same place, so it's in that caudal subsegment, where we have the sharp demarcation between the alveolar pattern and the normal lung. Here's a reminder for you to look over the heart to identify this pulmonary pattern. We have a lobar sign right here. We have airway branching. I don't see vessels in this portion of the lung. So there's an alveolar pattern in the middle lung lobe or caudal subsegment. Depends on if this is a right or left lateral view. We also have this rounded, broad-based soft tissue opacity dorsal to the cranial sternum, representing an enlarged sternal lymph node. Showing you that air bronchogram and the lobar sign and that enlarged cranial mediastinal mass or sternal lymph node. So these lungs are obviously abnormal. You can see some vessels, but then you start losing the vessels, and I don't see any vessels here. This is a pretty diffuse distribution. It's most severe kind of cranially and ventrally here, less severe up in the caudal dorsal, but I would call this an alveolar pattern that's fairly diffuse. What could cause this? So anytime we have an alveolar pattern, we tend to think about fluid in the airways, or there's fluid in the alveolus. The types of fluid are basically blood, pus, or edema. You can sometimes have tumors and atelectasis that will cause the alveolar pattern as well. Let's look at these causes a little more closely. So if I can't see vessels, it's an alveolar pattern. My differentials are blood, pus, or edema, or tumor or atelectasis. So how do we tell the difference? If you have blood in the lungs, it tends to come from either contusions, so the animal was hit by a car or had some kind of trauma, or a coagulopathy. And if you have contusions, it tends to be located anywhere, wherever the trauma occurred. If it is a coagulopathy, it tends to be more of a diffuse pattern. So this is a multifocal pattern where there's this dense interstitial to alveolar. There's an alveolar pattern with that lobar sign in the left caudal and right middle lung lobes. So this would be a multifocal distribution. And again, this animal probably had trauma. So he was run over, or there was trauma that occurred on both sides of his chest. Then you would evaluate the patient history to get a better idea that trauma was there. Here's an example of what diffuse pulmonary hemorrhage can look like, and that there's this diffuse increased opacity throughout the lungs. It's very difficult to evaluate or to visualize the pulmonary vessels. So this is an alveolar pattern, and this would be, when you see something like this, one of your differentials would include a coagulopathy. Pus, or bronchopneumonia, tends to occur cranially and ventrally within the lungs. The right middle lung lobe is the most commonly affected because it's the smallest lung lobe, and then also the right cranial and the left cranial lung lobes are often frequently affected as well, because when you have bronchopneumonia, the infection comes through the trachea and enters through the airway, and these are the bronchi that come off first. So you will get pneumonia like bacterial bronchopneumonia, or you can get aspiration, and they will both look radiographically similar with this cranial and ventral distribution. Here's the alveolar pattern in that cranial lung lobe, and in the middle lung lobe, here's our alveolar pattern, kind of cranially distributed and ventrally distributed. If you have a hematogenous type pneumonia, which in other words septicemia or hematogenous, because that infectious process was spread through the blood, it causes a diffuse pattern. So if you have this diffuse pattern, it could be a septicemic pneumonia. Sometimes it's a little patchy in that some areas are more severely affected and less affected areas. And so this would be an illustration of a diffuse alveolar, or it has some interstitial to alveolar pattern, and septicemic or hematogenous pneumonia would be a differential for this. We also already learned that another process that can cause a diffuse alveolar pattern similar to this is hemorrhage. And so differentials, if you saw these radiographs without the patient history, you may include septicemic pneumonia as well as a coagulopathy in your differential. Cardiogenic edema tends to occur from left heart failure, and it's going to have a hilar or a patchy diffuse opacity. So it tends to occur surrounding kind of the hilus of the heart, kind of in this region, the hilus. This is where the opacity will be most dense. Can extend peripherally. It can be patchy or diffuse. The right lung tends to be a little bit more severely affected than the left. In cats, it can occur anywhere, but if you have cardiogenic edema, you should also have an enlarged heart, specifically the left heart. And here's an enlargement of the left atrium and the left atrial enlargement. This is another example of an animal in heart failure. So the cardiac silhouette is enlarged. We'll talk about this later. The trachea is dorsally displaced. There's some left atrial enlargement. But there's this alveolar pattern in the caudal lung lobes. It's more severe centrally than at the very periphery of this lung. And the cranial ventral part of the lung is also less severely affected. So it's kind of in that hilus extending caudally and dorsally. Cats with cardiogenic pulmonary edema can have these patterns kind of more patchy and elsewhere. Like this cat, his heart is enlarged, but this pulmonary pattern is kind of multifocal and ill-defined and patchy. And so if a cat has a heart murmur or enlarged pulmonary vessel, or you're suspecting heart failure, the pulmonary pattern doesn't have to be perihilar for it to be cardiogenic edema. Non-cardiogenic edema has multiple causes. The location tends to be in the caudal dorsal lung lobes, with the periphery most severely affected. Usually around the hilus of the heart, it's like a less severely affected. So this is on the left side, the right side. There's this uniform soft tissue or fluid opacity. It's most severe out at the periphery, less severe centrally. That would be a classic distribution for non-cardiogenic pulmonary edema. Things that you would think about with this are electric shock, choking or near drowning episodes, airway obstruction, anything that causes leaky vessels will cause or can cause non-cardiogenic pulmonary edema. So this is a very long list of things that can cause it. You can get non-cardiogenic edema from things like infectious disease, so secondary to contusions or hemorrhage, because if those vessels are leaking, then you may have a non-cardiogenic component to whatever pulmonary pattern is present. So airway obstruction, near drowning, again, it's that caudal dorsal distribution. It's way out at the periphery of the lungs. And some of this is obscured on this ventral dorsal view because it's compressed by the lungs and its border effacing with that diaphragm. When you have acute respiratory distress syndrome or acute lung injuries or sometimes some diffuse pneumonitis things, you have a more diffuse distribution. So all of the lungs can be affected by these processes because all of the vessels are leaking. And so you may have more of a patchy or diffuse distribution also with non-cardiogenic pulmonary edema. And remember, we learned that we could also have a diffuse and sometimes patchy pulmonary pattern with like a coagulopathy or with infectious disease. And so that type of thing would probably be on your differential for diffuse changes. Occasionally, tumors will result in a focal lobar alveolar pattern. So this guy, there's this focal soft tissue opacity in the caudal dorsal lung. It has some rounded margins, and it can occur anywhere. In dogs, the caudal dorsal lung is a common place for primary lung tumors. In cats, it tends to be more generalized or lobar. Atelectasis can cause an alveolar pattern. It can occur anywhere. It's usually gravity dependent, or in this case, because the endotracheal tube is in the right primary bronchus, this left lung is completely atelectic, so there's no air in it, and so we have this alveolar pattern. Kind of these air bronchograms are overlying the heart. There's this diffuse soft tissue opacity. We have a loss of visualization of the pulmonary vessels throughout this region because we have that collapse of those airways, so they're no longer filled. This is a less severe illustration of some atelectasis just hidden over the heart, where there's some air in it because the airways are collapsed and not completely full and distended like they should be in the normal lung versus an atelectic lung. Here's illustrating this guy. So here's that opacity, and there's faint increased opacity over here. Notice we have a mediastinal shift to the right. The heart is off to the right, and we have these kind of patchy regions of increased opacity. So if we have that mediastinal shift toward the region of opacity, and that suggests that it is reduced volume and hypoinflation or atelectasis of the lung. This guy has some healing rib fractures. You can see them here and here from trauma. Just all three views showing you the right lateral, the left lateral, and the ventrodorsal view in this dog with atelectasis. So if you have atelectasis, sometimes these pulmonary patterns are inconsistent. So on this ventrodorsal view, there's some opacity in that cranial lobe and in the middle lobe, and we see more in the middle than the cranial here, probably because he inflated a little bit. So if you set him sternal and let him breathe for a little while and retake the radiographs, this atelectasis should improve. So now you have an understanding of alveolar pattern. Let's move on. So if you can still see pulmonary vessels, there are not nodules, you can ask yourself now, do I see more lines than normal? And if you do, you might have a bronchial pattern. You have to make sure it's not the vessels that you're looking at and more the airway walls. But this is what a bronchial pattern will look like. So we have, I can still see some, all these linear soft tissue vessels kind of going out into the periphery of the lung. But when I start looking at the lung, these lines, it just looks like some parallel white lines. There's a round circle here. There's some thickening right here. There's a parallel lines and parallel. It looks thick. These little white lines, which are the bronchial walls, are thickened. Sometimes they don't taper very well, so this bronchus should be getting more narrow as it goes to the periphery of the lung. And if you notice this bronchus is about the same size peripherally as it is up here proximally. So that suggests that we have like a primary bronchial type disease or bronchial pattern. So with the bronchial pattern, in the normal lung, we don't really see the airway walls, or we may see them as just very faintly thin white lines. In a bronchial pattern, we're going to start seeing thickening of that bronchial wall, and it will show up as all of these kind of parallel white soft tissue opaque lines, and or encircling, like if we're looking at them end on, we'll see all these donuts. So here we see these parallel hyperechoic, or white, increased opacity, soft tissue opacity associated with the bronchial walls. And they're thicker than they should be. So thickened airways are going to look like tram tracks or railroad tracks in long axis. And if we look at them end on, it's going to look like a donut. So when we see those vessels end on, they're uniform soft tissue or fluid opaque. But when we see like a donut where there's a soft tissue wall and air in the center, that's going to be that bronchial wall with a thick wall kind of like end on. This is a CT of a dog with a bronchial pattern. And what you can see is the airway, but see how thick the soft tissue wall is? So we have this really thickening of the bronchial, like all of these bronchial walls are very, very thickened. These bronchi are also dilated. And this is the thoracic radiograph on that same animal. It was very easy to illustrate and see these changes on the radiograph, on the CT, and much more difficult to identify on the radiograph. But you can still see that there's thickening of these airway walls. Here's like an end on one. So see how there's soft tissue. There's a donut right here. And we have this thickened soft tissue walls of the bronchi going through. So I see more lines. So if I look at this, I just see more soft tissue, like linear type structures. Here's the ventrodorsal CT images of that same animal. You can see the thickening of those primary or larger airways on this slice. And then over here, we'll see that thickening of the smaller airways. And then on the ventrodorsal view, the radiograph, you'll notice that it's more difficult to see, but you can see that there's some soft tissue thickening surrounding numerous bronchi. They look like little donuts. And here's thickening of this wall going out into the periphery. Here's another example of an animal with bronchial pattern. So notice how you see this thickened wall, all these little parallel hyperechoic, that's an ultrasound word, parallel soft tissue walls, like layering, radio-opaque walls. Here's the radio-opaque thickening. And then see how we have like circles and thickening of that soft tissue where it's end on. So when you start seeing lots of little railroad tracks or donuts coming through, then you're going to think about a bronchial pattern. So do I see railroad, tram tracks, donuts? Then it's going to be a bronchial pattern. Here's another illustration where you have all of this kind of linear soft tissue and rounded, really thick walls associated with all of the bronchi or the airways. So that would be a bronchial pattern. Looks like donuts when we look at them end on. Looks like those train tracks or parallel lines when you see them peripherally. This guy has less severe disease, but we have these parallel lines. We have all these regions where the bronchial wall looks really thickened. There's like these thick soft tissue walls associated with the bronchi, and even a milder case where we just start seeing, if I look at these lungs, there's just more lines than it should be, and then I see a lot of little donuts out here peripherally, so that would be a bronchial pattern. Problem you may have is that the pattern is the thickened airway. So if you see 1 to 2 end-on airways, it doesn't make a bronchial pattern. It's the fact that you see thickened airways in lots of them. Most bronchial patterns are mixed, so they're usually a bronchointerstitial pattern. And the point is for you to recognize that the airways are involved, because this will change our differential list in our treatment plan. So radiographic findings associated with the bronchial pattern are increased bronchial markings, thickening of the airway or bronchial walls, and dilation of the airway with lack of tapering. So we have some thickening of all these airways in this illustration. We have thickening of the airways, and these airways are slow to taper. Again, thickening of all of these airways. So that's a bronchial pattern. Here's that same dog where we have that thickening and dilation, thickened walls. And here's some bronchial walls. Here's a donut, some bronchial walls. Here's the end-on version. When you see a bronchial pattern, here's a close-up. Thickening of the bronchial wall is slow to taper. You can see that same one. Close-up over here where these bronchial walls are really thick. Lots of little thickened bronchial walls. Our differentials are going to be an eosinophilic process, most commonly. So most commonly when we have bronchial pattern, we're going to think about those parasitic processes or allergic inflammatory disease. So it can be an asthma cat, or it could be a dog with heartworms, or some other parasite. There is a primary eosinophilic process called eosinophilic bronchopneumopathy, which occurs in dogs, most commonly in Burmese mountain dogs. Rarely we will see infectious disease cause a bronchial pattern, and rarely we may see neoplasia, especially mast cell tumor, that can cause a bronchial pattern. So when you have a bronchial pattern and you think about these things, one of the first things you may want to do in that animal is deworm them and do a heartworm check, or a fecal float and check for parasitic disease. So what pattern would you expect to see with feline asthma? Correct, you would expect to see a bronchial pattern because of that allergic airway component. So if we have increased opacity in the lungs, you went through your algorithm, whether you can see vessels. If you can't see vessels, you have that alveolar pattern. If you can still see vessels and there's like more lines than normal, then you have a bronchial pattern. And if we can't see more lines than normal, we can see vessels, but their pattern is like fuzzy, then we have an interstitial pulmonary pattern.